Hello, my name is Jennifer Maranki, and I'm a professor of medicine at Penn State Health in Hershey, Pennsylvania. I'm an advanced endoscopist and the director of endoscopy, and I'm thrilled today to be talking to you about top tips for management of pancreatic duct strictures. When dealing with someone with a pancreatic duct stricture, it's very important to assess the patient and review available imaging. You want to understand the cause of the pancreatic duct stricture and also recognize that not all pancreatic duct strictures require endoscopic intervention. Obtain a detailed history to determine both etiology and symptomatology. Is this someone who's had prior bouts of acute pancreatitis, potentially with necrosis? Do they have chronic pancreatitis or risk factors for chronic pancreatitis? And how symptomatic is this pancreatic duct stricture? Are they having chronic abdominal pain? Are they unable to eat and maintain their weight as a result of this pancreatic duct stricture? Those are the things that you want to assess. In addition to an H&P, cross-sectional imaging is helpful for understanding the anatomy. A CT with pancreas protocol is useful for evaluating the pancreatic parenchyma and assessing for the presence and location of PD stones and chronic pancreatitis. You'll also be able to assess for malignancy or signs of autoimmune pancreatitis, areas of trauma, or ductal disruption. An MRI and MRCP are more useful in determining ductal anatomy, and an endoscopic ultrasound may also be used to assess the pancreatic duct and the pancreatic parenchyma. Next, you want to determine the location of the strictures and plan your approach accordingly. Strictures in the tail of the pancreas are more difficult to treat endoscopically from a transpapillary approach. Strictures in the head of the pancreas may be difficult to bridge, especially if large stones, particularly down low near the ampulla, are causing the obstruction. Assessing the ventral and dorsal ducts in relation to the stricture will help determine the best approach via either the major or the minor papilla. For example, if the entire ventral duct is stenosed, or if a large stone is obstructing the ventral duct, and the dorsal duct is fairly intact, then a minor papilla approach may be preferred, provided that the size of the duct is adequate. If the cause of the stricture is not apparent, sampling the stricture with a cytology brush to exclude occult malignancy should be pursued. It's very important to assemble an experienced endoscopy technician and nurse team. PD cases may be very challenging and require a variety of devices and expertise. It's critical to work with a team that's knowledgeable about both the procedure at hand and the various devices that may be used to achieve success. Expertise in long wire ERCP may be beneficial because tight fibrotic areas may be more readily traversed by use of a long wire technique with active tension while catheters, dilators, and stents are being advanced. While the majority of the ERCP that I performed is used with a short wire system, I occasionally like a long wire system in the setting of severe chronic pancreatitis strictures or in hilar cases. Additionally, some wires may be challenging for non-experienced users, so it's important for the guide wire to remain wet at all times, and thinner wires, those that are 21 thousandths of an inch or 18 thousandths of an inch, may sometimes have less pushability. Use these initial steps to gain access to the PD, perform a pancreatic sphincterotomy, and advance the guide wire across the stricture. A tapered tip sphincter tome may be helpful in obtaining access to a fibrotic stenotic duct, but note that a tapered tome may require a wire slimmer than 35 thousandths of an inch. A high performance wire is also critical to accessing the upstream duct. A stiff wire with a floppy tip with substantial pushability is ideal, and I favor the use of a 0.25 inch hydrophilic tip wire. A straight tip wire is often used initially, but an angled tip wire may be effective in navigating an ectatic duct. The angled wire may also more readily assume a shepherd's hook configuration, which is a safety measure, especially in a supple pancreas. For example, if you're dealing with chronic pancreatitis, chronic fibrosis, and even though you may have dilated side branches, it may be more challenging to actually perforate through one of those side branches. Whereas in a supple pancreas, in a pancreas that maybe has a stricture due to trauma and without any chronic fibrosis, it's very easy to cause a wire perforation. Often, a straight catheter like a 543 catheter is helpful for minor duct cannulations. This catheter requires an 18 thousandths of an inch wire, however, which may be somewhat more challenging to use. It's also critical to optimize fluoroscopy use. I found that some of my highest fluoroscopy use is during complicated pancreatic duct cases. So it's really important to use high resolution fluoroscopy and to appropriate collimate the view to minimize radiation exposure and achieve best results. It's very important to position the fluoroscopy screen in an area that can be clearly seen by both the endoscopist and the nurse. And when optimal images are obtained, it's helpful to capture a high-resolution image and save it as a reference so that it'll be up on the adjacent screen right next to your live fluoroscopy feed. This helps maintain a roadmap without having to add contrast material to the duct and helps minimize radiation exposure. Working with an experienced technician also helps decrease the amount of fluoroscopy used because the location of the wire and the location of the devices will be more predictable. You can perform stricture dilation with either passage or balloon dilators. Although passage dilators are available in a short wire form, the long wire passage dilators are preferred for me because of the active tension applied on the wire, which aids in advancing the dilator across tight fibrotic stenoses. The smallest dilator that we have available typically ranges from 4 French to 7 French and is fairly flexible and prone to bending. One size up, starting at 5.5 French and expanding to 8 French, is substantially more rigid and effective for dilation. Whereas I generally recommend a long wire for passage dilators, a short wire system is adequate for balloon dilation. The tips of the balloon dilators are fairly rigid and usually able to follow the wire without requiring the active back tension of a long wire system. For calcific strictures, the Sohendra stent retriever may be advanced over the wire and then used to screw into the stricture, effectively boring an orifice for passage. It also helps to use snug-fitting gloves for these types of techniques. You want to carefully select the stent size, length, and indwell duration. Most pancreatic duct strictures resulting from chronic pancreatitis are refractory to dilation alone, so dilation plus stenting is recommended. I ideally like to start with a 7 French stent, but depending on the size of the duct, I may need to downsize to 5 French or upsize to 10 French. The stent diameter should not be larger than the greatest diameter of the main pancreatic duct. In terms of stent length, you want to aim to bridge the dominant main PD stenosis that allows the proximal end towards the tail to be situated in the center of the duct, without pressure on the adjacent walls. In our experience, a 7 French stent from the major papilla tends to hit at the genu, which then applies pressure to the surrounding duct, leading to ductal damage and stricture formation and potentially patient discomfort. As stents are exchanged, it's helpful to vary the stent length to avoid secondary PD strictures at the proximal aspect of the stent. For symptomatic, benign main PD strictures that are responsive to stenting, the ESGE guidelines recommend a single 10 French plastic stent to be placed for the duration of 1 year. Inasmuch as PD stents are prone to clogging, these may need to be exchanged on the basis of symptoms or signs of stent dysfunction. On-demand stent exchange has been associated with infectious adverse events, whereas a predetermined stent exchange protocol has not. You also want to use multiple side-by-side plastic stents or place a fully covered metal stent for refractory strictures due to chronic pancreatitis beyond 1 year. If the stricture persists beyond a year, and after discussion at a multidisciplinary conference including your surgical colleagues, the gradual placement of more stents to progressively dilate and remodel the duct is warranted. This process seems to be better tolerated than does placement of a fully covered self-expanding metal stent, in part because the smallest fully covered self-expanding metal stent at our institution is 8 millimeters in diameter. Compared with multiple plastic stents, metal stent placement in the PD is associated with a higher rate of stent migration, de novo strictures, and severe pain. Consider additional options for dealing with large PD stones and strictures not amenable to ERCP. Extracorporeal shockwave lithotripsy, or ESWL, is a very effective method for removing stones in the head and body of the pancreas that are greater than 5 millimeters in size and radiopaque, and it is considered first-line therapy for an obstructed main pancreatic duct. ESWL use is limited in the United States because despite its efficacy, few centers offer it, in part because of its off-label use of the lithotripsy device and regulatory hurdles. Digital pancreatoscopy-assisted electrohydraulic lithotripsy is another option for large stone removal. This procedure may be technically challenging depending on the ductal anatomy and the location of the stones. Additionally, the scope can be used to directly visualize strictures and perform forceps-directed biopsies. The duct must be dilated to at least 4 millimeters to accommodate the 10 French pancreatoscope, and ideally the duct will be straight and not tortuous. EUS-guided pancreatic drainage is another option, including EUS-guided PD rendezvous or EUS-guided transmural drainage to the stomach or duodenum. These techniques should be performed only in expert centers with adequate surgical support and after a multidisciplinary discussion. Finally, surgical intervention, in either the form of resection, drainage, or combination of both, may be performed for symptomatic PD strictures not amenable or responsive to endoscopic treatment. Thanks very much for your attention, and thanks to GIE for the opportunity to speak to you today.